Hello, my name is Börjesson. I'm a professor and a cardiologist from Gothenburg, Sweden. And my talk today is about the Swedish physical activity on prescription method using a patient-centered perspective. As a background, you all know that physical inactivity is a global health problem, and a large part of the world's population are insufficiently active. And we need methods to increase the level of physical activity, not least for patients in the healthcare setting. But we also have barriers to lifestyle counseling in healthcare. When you talk to the healthcare personnel, they will say that we need more education, we need more time and structural support to do this, and it's overwhelming. But they also say that it's hard getting people to change behavior, and this is of course true. But there is one thing missing, I think, which is very important, and this is the motivation of ourselves, the healthcare personnel. And this study performed at the Karolinska University Hospital in Stockholm by our PhD student Amanda Ek showed that, yes, the healthcare personnel in this thoracic department thought that it's very important to work with lifestyle behavior change in all four lifestyles, but they were not so good at asking about lifestyle behavior, and even worse at giving counseling. And they gave the same reasons: clear routines missing, clear goals missing, and the support from management lacking. So clearly we need a structured method to help increase physical activity in the healthcare setting. The patients, they are very positive. They say that physical inactivity is one of the, maybe the most important lifestyle behavior change they need. They also say, of course, they are responsible for their own behavioral change. 93 to 99% say that. But importantly, highlighted in red, 76% of the patients state that it's also the responsibility of the healthcare system to help them change their behavior. And this is something we really should take into our hearts. And they, even more, they say in different surveys that we don't do that. They expect us to ask about behavioral and help them to change behavior, but they don't think we do that. We have different approaches to physical activity promotion. Traditionally, general advice has been used for numerous years and with limited effect. And more recently, added support like pedometers, diaries, and follow-up has helped increase the efficacy of such methods. And even more complex systems like the exercise referral schemes has been introduced. When you're going to healthcare personnel, you are prescribed an activity and you go to expert in physical activity, be a physiotherapist or exercise physiologist, and you perform in their care activity for 8, 12 or 16 weeks, for example. And then exercise on prescription models, which is usually lumped together with the exercise referral schemes, have been introduced. But when looking today at the Swedish PAP system, it differs from the ERS in key components. First of all, it's based on the national guidelines from the National Health Bureau and Welfare that says that insufficient physical activity should, the methods used to increase the activity in those patients should be counseling with individualized written prescription, or counseling with a pedometer. Perfectly falling into place here is the Swedish physical activity on prescription treatment, which is individualized and person-centered, and consists of counseling, person-centered dialogue with a physical activity recommendation, usually written, and an individualized and structured follow-up. The evidence used for the actual prescription comes from the FISBOK, which is the Physical Activity in Prevention and Treatment of Disease. And also, when you have a prescription, we can use a network of collaborating activity organizers. The Swedish FISBOK then is the evidence-based book where you collect evidence for health benefits of different types of activity and for different diseases and risk factors. And it's based on the dosage, the type of activity, intensity, frequency, and duration, what you in the US would call the FIT principle. But also in these chapters are side effects, contraindications, and indications. And the FIS book is on the website www.fis.se, and it's freely downloadable in the English version, 650 pages. The book has been translated to several languages, including Norwegian, English, and Vietnamese, and it's used in the medical education and in Sweden and elsewhere. So, again, the Swedish PAP treatment, the differences in the central parts, again, is the counseling and prescription, which is individually tailored. And you base your prescription on the health status, of course, and diagnosis using the FIS book, but also the level of physical activity, the readiness to change, what the patient's motivation and interests, what is possible to do, and the environmental structural support for the patient and resources and so on. And the key here is that this is not one size fits all. This is not the same prescription for every patient, although it might be the same disease. Because the physical activity history is important, and previous experience and the habitual, are you habitually active or are you sedentary? That's important. And then comes the FIS book, the ideal prescription, so to speak, coming from the FIS. This is illustrated here by FIS 2017. But this prescription has to be adjusted according to many things and not stop here, because this is then one size fits all. The key here is that you can be prescribed activities both home-based and in the community setting or gyms. Of course, a risk assessment is included in all these individualizations. And of course, if you have two concomitant diseases, you have to take both into consideration in terms of risk assessment. Behavioral change and readiness to change of the patient. It's no strange here. We use the trans-theoretical model and try to evaluate the patient's readiness to change. In the person-centered partnership, in the person-centered dialogue, we use the person-centered principle. That is that you have a narrative, that you initiate a partnership, you have a shared decision-making, and you also have a safeguarding of the partnership and documentation. So person-centered care is a real important part of the Swedish PAP. And also in Sweden, there's lots of research on this topic. And that would, in the US, you would maybe call this patient-centered care. In Sweden, we call it person-centered care. And another difference is the individualized follow-up. There is no time limit there is no 8 weeks, 12 weeks, 16 weeks of training like a cardiac rehab program. This is for life. And there is an individualized follow-up. And of course, you should base that follow-up on the patient's need and prior experience, but also you have to adjust the program according to the goals and targets, maybe change risk profile and the effect of the treatment so far. And the fifth difference is that in the Swedish PAP system, anybody in the healthcare system which has sufficient knowledge can prescribe activity. But of course, you have to know about the health status of the patient or be in touch with the prescribing doctor to know that. You also have to know about the PAP system and the local routines. So, is it working? The Swedish PAP system has been subject for many theses since the first thesis on the subject was published in 2008. Also, a number of additional studies have been published looking at things like adherence, efficacy in terms of increased physical activity levels, and effects on metabolic parameters. And also different versions of the PAP has been looked at, and there is long-term studies coming. And also there is qualitative studies on the patient and on the staff perspective. This is the study from Roger and co-workers where we looked at the 2-year follow-up in the primary care setting of the PAP system, looking at physical activity level increasing up to 12 months and quality of life remaining increased after 24 months. and this is the qualitative study on the staff's opinion. And again, they highlight the need for time, resources, and structured support from the management. And we believe that's a really important part of the introduction of such a scheme, that the prescriptivity on prescription model is a structured way in normal healthcare. But what about the long-term effects? The Gothenburg physical activity on prescription study is the longest ongoing study on the subject, with 444 patients, which were followed up for first 6 months, looking at the efficacy of physical activity level, and then for the non-responders, added fitness tests and added PAP, and looking at the efficacy of that, and then a 5-year follow-up, which is now ongoing, and we don't know the results yet. First of all, the 6 months showed an increase in metabolic parameters parallel to the increase in physical activity. And also, qualitative study looked at the predictors of the increased physical activity and what predicts that at 6 months. Interestingly, as you can see here, the potential predictors for increased physical activity level at 6 months included confidence in readiness to change, their PA level of the patient, the positive value for measure of physical health, and a BMI under 30. So these are some of the factors, predictors, that could be used in clinical practice to predict success of the PAP system. There has been a systematic evaluation of the PAP apart from the PhD thesis, and this was published in British Journal of Sports Medicine in 2019, and following the grade system and all the prerequisites for a systematic review. And the PICO was, of course, patients with insufficient physical activity, adult, in healthcare system. Intervention was the Swedish PAP, comparison was no PAP, and outcome was, among other things, physical activity level. And as you can see here, most studies had physical activity level as an outcome, and therefore the highest evidence was collected here. And to summarize, the evidence using the grade system from the systematic review of the Swedish PAP system is that it increased the physical activity level compared to no PAP. And this was a level of evidence 3 out of 4 according to grade. What about the patient's experience? The patient's experience in another qualitative study highlighted the need for the activity counselor, and also flexible support, giving flexible support, I would say, to the patient according to their needs. And again, this really reflects back to the individualized person-centered dialogue. And we believe that this is a key to the success or the efficacy of the Swedish model, that we can reach people or, so to say, higher hanging fruits, which are less accessible to behavioral change and need more support in that. So the Swedish physical activity as a method of treatment, physical activity and prescription method, the indications is, of course, it could be used as a first-line treatment, or it could be used as a complement to medical treatment for diseases and risk factors. And the goal is, of course, to achieve health benefits and risk reduction, and possibly to reduce medication and increase health economy, at least in the long run. But there are also emerging studies on the health economy for the method, although we need more studies in this area. Very interestingly and nicely, the Swedish PAP model has been used or been chosen as best practice within the European community, and therefore it was supported by the EU with a grant to spread, disseminate, and educate about the Swedish PAP model to 8 other European countries. And this project has just been completed, going on for the last 3 years, with the large part of the education taking part in Gothenburg. And now the model will be the subject of an OECD report in the coming year, looking at these best practices. So we are very proud of that, and we think that also is significant for the spreading of such models. So in conclusion, the Swedish PAP model is a model for exercise prescription to increase physical activity in insufficiently active people in healthcare. And we believe such a model should be part of regular healthcare, either the Swedish model or a similar model. But we do think the person-centered approach, as in the title of this talk, is essential for the success of the model.